to you, ma'am.
Yeah, hi. Good evening to one and all. I thank the National Board for giving me this opportunity to present a webinar. So I hope I'm doing justice and I can help out my fellow colleagues and junior colleagues, and I can probably, help them out in their exams and also help them understand this topic better. So I'll go into the topic. Today we'll be discussing regarding the benign tumors and tumor-like lesions of the oral cavity. A brief introduction about me. I'm Dr. Krishna. I'm practicing ENT surgeon in Bangalore.
Click once on the slide, then try to move it.
1 second, just a second.
Click once on the slide.
Yeah. Can you? I think it's working now. All right. So about the topic proper, a small introduction. Oral cavity is one of the most common sites of tumor and tumor-like lesions. I think all of us would have seen it in day-to-day practice. So what are the most common predisposing factors? So the poor oral hygiene, removable or ill-fitting dentures, and then harmful habits like tobacco chewing, smoking, malpositioning of teeth, and mechanical irritation. These are some of the factors which predispose to reactive lesions and tumor development. Initial clinical diagnosis must be accurate because we should not miss out on any pre-malignant or malignant lesions. That is why we always stress upon, all our seniors stress upon the fact that we are supposed to examine every single subsite before we come to a proper diagnosis. So today I will be speaking about, I'll be restricting myself to the benign tumors and tumor-like lesions of the oral cavity. I will not be touching upon the odontogenic tumors because I think that itself is a separate topic which needs even detailed discussion. So this is WHO's histological classifications, which was published in 2017. So they have grossly classified the tumors of oral cavity into epithelial tumors and lesions, papillomas, tumors of uncertain histogenesis, soft tissue and neural tumors, oral mucosal melanoma, salivary type tumors, and hematolymphoid tumors. So amongst this, one of the most commonly identified or diagnosed entity will probably be papillomas and squamous cell carcinoma. And also we come across a lot of fibromas in our day-to-day practice. So this is a very important table, which I don't think there's any easy way to remember it, but we will have to remember it at least for exam point of view. So right now I'm going to be talking about the congenital lesions or variants of normal. So first important variant of normal that we see in regular day-to-day practice is nothing but tori or exostosis. So exostosis, as the name suggests, is nothing but bony outgrowths that are most commonly seen. So they are of two types: torus palatinus or torus mandibulanus. That is, they are most commonly seen in the hard palate and, as the name suggests, over the mandible. So the etiology of this is usually very poorly understood because there is multifactorial etiology, but genetics is often a very dominant factor. That is, if the father has it, there's a good chance that the son might also have it. Because of the etiology being multifactorial, epidemiology is also highly variable. That is, like different population, there's no particular population group in which this disease is most commonly seen. And it varies about 5 to 30%. So the growth of this tori or exostosis is ideally very variable. That is, they have a very negligible growth to start with, and that is, it's usually very slow, and suddenly it might increase in size. But because of the steady growth, they are often they are unlikely to be inflammatory hyperplasias or neoplasms. All right, and yeah, so as said before, they are most commonly seen in the palate, or they are seen along the lingual aspect of the mandible. All right, so they're nothing but focal nodular enlargement of the cortical bone, and typically they are small in size, but as I said before, they can steadily grow and achieve one particular size. Management is usually not recommended for them because they don't really cause any functional problem. However, because of this kind of a mechanical obstruction, if they are going to be this big, all the patients, and generally people have the tendency to keep rubbing them with their tongue, or like when they are trying to do, when they are brushing, they try to probe it. So that repeated trauma can lead to traumatic ulcers, which are usually very slow to heal, in which case surgical removal is the treatment of choice. So what is the differential diagnosis of this? It's usually Paget's disease or fibrous dysplasia. However, Paget's and fibrous dysplasia, we have to remember that other bones will also be affected. Next, common variant, or like a normal variant that we come across, is unencapsulated lymphoid aggregate. So these are something that most of us tend to miss out on regular examination, and the patient most commonly come to us with like the complaint being they find they have a foreign body sensation in the tongue, or in the pillar, they notice it in the tonsillar pillars, and that's how they come to us. So these are normal structures, but we have to remember that they are distinct from the palatine and the lingual tonsils. And also so there's a lot of like there's a lot of confusion regarding whether you're part of palatine tonsil, part of Valdez-Singh or not. So I think it's better to stick to the standard textbooks which say that they are not part of the Valdez-Singh. All right, so they are they may be very small to start with. However, they may increase in size as a result of reactive process, or they lymphoid neoplasms could lurk there. Okay, so this is something we have to keep in mind. So clinical features, they usually involve the posterolateral aspect of the tongue, and they're found in the anterior tonsillar pillar, posterior wall, soft palate, or in the dorsal tongue. So usually management is not required because they are very, like they're just normal variants. However, if there is a progressive enlargement or ulceration, then biopsy is a must, because as I said before, they could have, like lymphoid neoplasms in them. All right. Next common variant that we usually come across is the Forday spots. So again, this patients most commonly present to us because one fine day they decide to examine their oral cavity, and then they find white spots, they get scared, and they come to us. So these are nothing but ectopic sebaceous glands. All right, so you can see them very clearly here, these white tiny spots, and they are most commonly seen in the buccal mucosa. They are also found over the vermilion of the lip. So they have no malignant potential. They are just sebaceous glands in the mouth. So all we have to do is make sure that the patients are reassured, and we have to stress upon the fact that treatment is usually not required in them. Okay, next important entity is the lingual thyroid. All right. This accounts for 90% of all the ectopic thyroid tissues, and they are most commonly found in the dorsum of the tongue and in the midline. And why is that so? That is mainly because of the foramen cecum. So as we all know, the embryogenesis of thyroid is usually from the foramen cecum, from which it descends down. So sometimes what happens, this globulated structure that we see here, this is an image of the lingual thyroid. So they are usually found in 1 in 18,000 to 1 in 1 lakh live births. 90% of the time they are asymptomatic. Okay, but they can be associated with hypothyroidism, mainly because of the fact that the normal thyroid tissue is absent in such patients. However, in like neonates and in children, they can be, if they're going to be this big, if they're going to be huge enough, they can cause mass effect, and they can. That is most common, most common feature of a mass effect is airway obstruction. All right. So the second thing is, if they grow into, most commonly we find them in adults. If they grow into adulthood, the symptoms may increase, especially during times of increased metabolic needs. That is, during pregnancy or in case of an acute stress. That's when they suddenly tend to increase in size. And malignant transformation is often rare in them. Okay, so what is the treatment of choice in case of a lingual thyroid? All right, so in lingual thyroid, in hypothyroid, if the patient is hypothyroid, obviously thyroid replacement therapy is the treatment of choice. So there are two advantages to a thyroid replacement therapy. That is, one is it will take care of the hypothyroidism. At the same time, it also reduces the size of the lingual thyroid, which may in turn decrease the obstructive symptoms. Okay, so this is in case of hypothyroid patients. However, in patients with symptomatic patients with obstructive symptoms and other things, surgical excision is the treatment of choice. So there are different routes of surgical excision, some of which that we have to the students have to remember, for at least for exam point of view and clinically also, is lateral pharyngotomy, transhyoid pharyngotomy, transoral robotic excision with carbon dioxide laser or cautery. Amongst these, now the most preferred route is robotic excision with carbon dioxide laser, mainly because of early recovery, and the chance of bleeding is less and complication is also less. And as I said before, in many patients, this could be the only source of thyroid hormones. So therefore, post-surgically, hormone replacement may be needed in 70% of the individuals. Now, coming on to the developmental cyst. So these are broadly classified into three different types. So you have dermoid cyst, you have duplication or enteric duplication cyst, and nasoalveolar cyst. So these are usually rare entities which are found in the oral cavity. Amongst this, so let's first discuss regarding the dermoid cyst. So dermoid cysts are usually, as we all know, it's nothing but they're cystic masses which are found along the fusion line, embryonic fusion lines, and they typically contain elements of epidermal appendages. Most commonly include, like, they have hair follicles, they can have sweat gland, they can have connective tissue also. Histologically, they are nothing but they are lined by squamous epithelium, and again they contain all the three derivatives from all the three embryonic layers. So about 7% is found in the head and neck, amongst which most important statistics is 6.5 to 23% are found in the floor of the mouth. Again, like a lingual thyroid. And that is mainly because of the fact that, this has to be remembered, because especially if we are called to see a neonate with some kind of a airway obstruction, we have to keep in mind that dermoid cyst could be one of the differential diagnoses. Coming on to enteric duplication cyst. So these are nothing but choristomas. So what is a choristoma? A choristoma is nothing but a normal tissue in an abnormal location. Okay, so this is nothing but when we find a gastrointestinal mucosa anywhere in the line, like in the gastrointestinal line, from the oral cavity, if we find it there, then they're called as duplicate. They're considered as choristomas. So the enteric duplication cyst, again, see, they do not cause much symptoms at all, but they can produce mass effects like dermoid cyst. So they can cause functional problems such as difficulty with deglutition, speech, or respiration. So the treatment for both the enteric duplication cyst and the dermoid cyst is complete excision. We have to make sure that we are removing all the layers so that they do not recur. Okay. So another very common entity that we come across in day-to-day practice is the nasoalveolar cyst. So, I mean, common meaning, like, we have to, again, keep in mind, it's not as common as a fibroma or after ulcers that we see. So these nasoalveolar cysts, they are also called as Cleestat cyst. So they occur because so as we all know, in the development, in the embryology, the median nasal process and the lateral nasal processes fuse to, like in case of development of the nose, we have all read that. So whenever the nasal epithelium gets trapped between the lateral and the median nasal maxillary process, these kind of cysts can develop. So they're usually identified, they usually become symptomatic in adulthood. So they remain dormant and suddenly they increase in size in adulthood. That's how we find out it's there. So how they present is, in the nasolabial area, there will be unilateral elevation of nasal ala. So when you see that, the first obvious diagnosis is going to be vestibulitis. But the second thing that we have to keep in mind is nasoalveolar cyst. So they are nothing but smooth mucosal covered mass, often seen in the gingival circle. So you can see it here. Okay, and complete excision of it is done through a sublabial approach. So one thing we have to keep in mind post-surgical is, whenever we are going through the sublabial approach, there is a good chance that the nasal mucosa might get disrupted, in which case risk of oronasal fistula increases, and that becomes a very difficult problem for both the surgeon and for the patient to handle. So we have to make sure that when we are operating on the patient, that the chances of oronasal fistula is not there. If it is there, it has to be repaired on table. All right. So this is a picture of a duplication cyst which is found to be involving the tongue. So the common congenital or the congenital lesions and the normal variants is I think we have covered most of it. Now I'm going into inflammatory, reactive, and exophytic soft tissue lesions. This is again one of the most common conditions that we encounter in our day-to-day practice. So this is a very broad description. So what do they include? So they include a large range of commonly occurring exophytic lesions of the oral mucosa. So that is most commonly inflamed fibrous and granulation tissue. Again, why do they happen? They most commonly happen because of masticatory trauma. That is, as a result of chronic trauma from ill-fitting dentures, biting, or contact with fractured teeth. It can also be related to chronic inflammatory stimuli, like overhanging restoration post dental infection, dental procedure, or calculus. And in some level, in some patients, because of circulating hormones or medication play a role. We'll know which particular lesion I'm talking about with respect to circulating hormones. So the biggest advantage in all of these lesions is, once we excise the lesion and remove the chronic irritant, majority of them will not recur. So that's a good thing. Okay, so most commonly encountered is the fibroma. So this you can see here in the labial mucosa. So this is a fibroma. So what is a fibroma? Most commonly, it's a benign tumor which usually occurs following a trauma or a cheek or a lip bite. All right. So most commonly, it is seen in about 1.2% of the adults, with 66% female predilection. All right. They are usually solitary. They are not larger than 1.5 centimeter. Most of the times they are asymptomatic. Patients, again, they feel something weird in the tongue or the buccal mucosa, mostly in the buccal mucosa or in the lips, and that's how they present in the OPD. So they are sessile or pedunculated. They're usually sessile or pedunculated firm mass, as I said before, occurring from the buccal mucosa, labial, or the tongue mucosa. So we have to excise them completely. And histopathology most commonly shows dense, minimally cellular fascicles of collagen, which are arranged together in, like a concentric pattern, and they are relatively avascular in appearance. So bedside excision would suffice for such patients. And recurrence is often unlikely, provided the causative trauma is removed. Right? Next encountered lesion is the fibrous inflammatory hyperplasia or epulis. All right. So these are nothing but reactive inflammatory lesions, and again, they are mostly due to ill-fitting denture. So you can see typically here this mass, which is found exactly at the place where the denture sits. Okay, so they are usually seen in less than 0.5% in general population, and they account for about less than 2% of the exophytic soft tissue lesions. So when you see this particular image here, like the second next line will make sense. So they are split by the edge of the denture. So one part will usually be under the denture, and the other part will be lying between the lip or the cheek and the outer surface of the denture. Okay, so they usually become less edematous and inflamed following chronic irritant removal. However, the only problem is they rarely resolve entirely. So you can go ahead and excise it, but the problem is when you put an ill-fitting denture again, there's a good chance that they can recur. Next is inflammatory papillary hyperplasia. So this group of aggregates that we see in the heart palate is the typical appearance of an inflammatory papillary hyperplasia. Again, the exact pathogenesis is unclear. It is often associated with chronic denture irritation or denture stomatitis due to chronic candidal infection. Okay, so they're seen in about 3 to 4% of the denture virus and typically occur in the heart palate, central heart palate. So because of their association with candidal infections, mild cases you can usually surgical excision is not warranted, so we can just treat with topical or systemic antifungals and change the denture and see. However, if they are very florid, then surgical excision is the treatment of choice. However, these variants have a tendency to bleed, so therefore electrocautery, cryo or laser would be a better option. Okay, so next is the mucosal ulceration. So aphthe is something that all of us have had at least once in our life, especially during exams, and like it's also one of the most commonly encountered thing that patient comes to us again and again. So what are aphthe? So these are nothing but recurrent oral immunological ulcers that are multifactorial in origin. So the word immunological itself suggests that they usually occur during time of stress. So why do they happen? They happen because there's a T cell mediated damage to the epithelial basal layer. Okay, so we can broadly classify them into 3 different types. So you have minor aphthe, you have major aphthe, and herpetiform aphthe, depending upon the features. So patients typically present to us with burning sensation, pain, and it can become a problem for the patient from in a day-to-day basis, because like they'll stop eating well, and like it is quite painful. So what is the treatment? Treatment is usually symptomatic. So we have 3 broad classifications. We have symptomatic treatment include lidocaine jelly and like local antiseptic creams and local steroidal creams like triamcinolone we can try. In recurrent patients, episodic medicines can be given. Episodic medications include betamethasone mouthwash and again steroid creams, and sometimes even underlying fungal infections can predispose it. So we have to give antifungals accordingly. Topical preventive medications include doxycycline mouthwashes, betamethasone mouthwashes, and systemic preventive medications. Usually, it does not lead to that level, but studies have shown that mycophenolate mofetil and oral doxycycline and all have and azathioprine, all those immunological modulators also help with recurrent oral ulcerations. So let us see what are the 3 different types of ulcers. Okay, so we have minor, major, and herpetiform ulceration. So what are minor aphthous ulcers? These are the most common form of aphthous ulceration that we see in a day-to-day basis. So they are less than 10 millimeter in size, in diameter. They last for about 2 to 3 weeks and often heal without scarring. They can be multiple, but usually they're less than 10 at a time. And they're usually seen in the front of the mouth, commonly in areas of mucosal trauma. Meanwhile, when you look at major aphthe, they are larger than 10 millimeter in diameter. They usually last for more than 3 months. They can heal with or without scarring. And Usually they are single, but like 1 to 3 ulcers can also be present at one time, and they're usually found in the back of the mouth. And herpetiform ulceration are nothing but these are the least common form of aphthous ulcer. Pardon me for the spelling mistake. They are less than 5 millimeter in diameter, and they can last up to 2 weeks. They also heal without scarring, but they are about 100 ulcers at a particular time. They usually coalesce into one large area, and they can they can mimic a neoplasm. So that is something that we have to keep in mind when we see a patient, and these are most commonly seen in immunocompromised individuals. So the most common form of aphthous ulceration that we usually see is the minor aphthous. Okay, so next is pyogenic granuloma. So when I was discussing about the inflammatory lesions, I first mentioned that there is a particular there are some entities which happen because of hormonal variation, and one of the most common is the pyogenic granuloma. So this is typically associated with pregnancy, mainly because of the increase in the estrogen levels. All right, so they can occur on any mucosal surface, and they are subject to acute or chronic trauma or infections. So as I mentioned before, most commonly associated with pregnancy or recent tooth extraction. So they have a female predilection, that is 2:1 ratio. So clinically, this is how they appear. So they are seen as a raised or pedunculated lesion, often less than 2.5 centimeter in size, but they have a tendency to bleed even with minor trauma. All right, so that should be kept in mind when we are excising them. So the common sites include labial or buccal mucosa and the tongue. So surgical excision and successful removal of irritant often result in low rate of recurrence. But the only caveat is they can, they can bleed. So we have to keep that in mind when we are doing a bedside excision. Okay. This is a very interesting entity. It's called as the necrotizing cyelometaplesia. So this is a self-healing, ulcerative, inflammatory reaction of unknown etiology. So every single word is important, because why it's why I'm stressing on the importance is this is one of the most common entities which is confused with a malignancy. All right, because even when we see this clinically, it is looking it does look suspicious, or it does look like a malignant thing. So this may be due to repeated trauma, local trauma resulting in vascular compromise. So most commonly they involve the minor salivary glands, which is why they majorly involve the heart valve. Okay, so they cause they usually patients present to us with painful ulceration, and as I said before, it stimulates a malignancy. However, histopathology is the diagnosis of choice. So when we see a lesion like this, usually we tend to give topical medication, see if they heal. So if it's going to be a non-healing entity for more than 2 weeks, then we have to go ahead and do a biopsy. The same thing holds good for an aphthous ulcer also. That is something that I didn't mention. So for any lesion, ideally we wait for 2 weeks. If there is no improvement within 2 weeks, or if it seems to be unrelenting, then we always have to keep in mind that tissue diagnosis is must. It will help in clinching the diagnosis. So in histopathological examination, often lobar necrosis and sialadenitis is seen, mixed with a squamous metaplasia of excretory ducts and acini, because it involves a minor salivary gland. However, it can be confused with squamous cell carcinoma. So therefore, that should also be borne in mind when we are giving the tissue for diagnosis. Often self-limiting, and healing takes place within 3 to 6 weeks, and this can still be found in conjunction with malignancy. So that is something I'm reiterating again and again. We have to remember that this can be confused with the malignancy, and malignancy can also be found to be associated with this. Okay. Next is amyloidosis. All right. So amyloidosis is something that all of us have been studying since our UG days. So it's nothing but abnormal deposition of extracellular fibril proteins into the tissue. So what is the most common manifestation in head and neck? It is macroglossia. So there are about 23 different proteins that have been identified in amyloidosis. So these can be dialysis-associated amyloidosis, fibrillar proteins, and multiple other proteins are there, which I'm sure is given in all of the major textbooks. So they usually start off as a mucosal, like submucosal mass, okay, and progressively increase in size, resulting in a lesion something like this. See? Okay, so this obviously will all get confused with malignancy. So diagnosis again is tissue diagnosis. So they can result in function of the tongue becoming limited. So biopsy in green fluorescence, right, will show this apple green birefringence after Congo red staining. Treatment of underlying cause of amyloid deposition has to be done, and also local excision in case of macroglossia. So unless we treat the cause, it's not going to get better. There's still a chance that it can recur. All right, so now going into, we've seen the inflammatory lesions, we've seen congenital lesions, and now we're going into the benign neoplasms. So grossly, I'll be talking about these benign lesions. So I'm going to be talking about papilloma. I'm going to be talking about keratoacanthoma, granular cell tumor, AV malformations, lymphatic malformations, neurogenic tumor, lipoma, ameloblastoma, pleomorphic adenoma, and tumors of muscles. All right. So one of the most common entities that all of us see, and there's being talked about so much these days, is the HPV virus infection. So this is a benign variant of it. 11 and 16, as we all know, is the oncogenic genotypes, and so they are nothing but unique squamous derived entities of oral cavity and oropharynx. So what happens? What is the pathogenesis? So they typically infect, when we see here, they typically infect the basal epithelium, basal cell layer of the epithelium, following a mucosal trauma. Then what happens? The genome gets integrated into this. So, there's going to be replication of these E1, E2, E6, E7 proteins, and then, there's going to be replication, and finally virion is going to get released, right? So what happens is it leads to a clinically distinct lesion. The biggest disadvantage with this is that one lesion can lead to multiple lesions. As we all know, the satellite lesions is very, very common. So because of that, they're transmitted by direct contact with another infected patient. Okay, so epidemiology, they are seen in less than 5% of all oral biopsy specimens. Obviously, patients living with HIV have a higher risk of HPV-induced growths than immunocompetent patients, mainly because of the, the immunocompromise there. So they are, as I said before, they are associated with 6 and 11, and third to, they are often seen in third to fifth decade of life. And okay, so you can broadly classify them into 3 different types. There's Verruca vulgaris, there's Condyloma acuminata, and or the genital warts, and there is something called as a florid papillomatosis. So Verruca vulgaris is often cutaneous. It is associated with HPV2 and HPV57. Condyloma acuminata, or the genital warts, are often associated with HPV6 and 11. This is an image of a florid papillomatosis. So basically, they are also called as ichthyosis hysteris. That is, it's a congenitally acquired deforming skin papillomatosis, and often is associated with Down syndrome patients. Okay, and yeah, so when we see, so this is the typical appearance of a papilloma. So they're nothing but, they're less than, they're about 1 centimeter in size. They can be, white to pink. They're often verrucous. They're like florid, like a flower, and and Condyloma acuminata are nothing but larger. They are larger than viral papilloma. So this is a Condyloma acuminata. They're flat top with smaller satellite lesions. All right. So they typically involve the lingual, buccal, labial mucosa, and the tongue. All right. And there's another entity called as a focal epithelial hyperplasia, or the HEX disease, which is nothing but numerous soft, well circumscribed, flat sessile papules distributed throughout the oral cavity. So as I said before, if it's very florid, then we'll have to suspect some kind of an immunocompromise like HIV infected patients. So treatment is going to be again local excision. The thing with oral papillomatosis is that it is not just functional reason that functionality is not the only reason why we should remove it. There's also a chance that they can undergo malignant transformation, which is seen with most of the oropharyngeal carcinomas these days. So therefore, when we look at a lesion and if we feel there are multiple satellite lesions, it's better to go ahead and remove them surgically. So most important thing is we have to take care while removing the HPV-induced oral growths. And this is mainly because when we aerosolize the viral particles, they can go and cause a lesion elsewhere in the oral cavity, or they can spread also. So cold steel is not preferred anymore. It's usually electrocautery or laser, to ensure complete excision. Florid disease, often it becomes a big challenge to, manage surgically. All right. The next one is keratoacanthoma. So this is a very interesting variant. This is typically seen in sun-exposed areas in the skin. And they are often mistaken as squamous or basal cell carcinoma, mainly because of their rapid growth. And they are often, as I said before, because of their predilection to sun-exposed area, they're usually seen in the upper lip. So they are dome-like, they are sharply demarcated, fixed to the surrounding tissue, and capped by thick keratin pearls. So that is the clinching diagnosis in histopathology. So as usually what happens is the lesion matures, it exfoliates and it heals spontaneously. However, if we want to ensure, if we want to go ahead and excise it, then wide excision is required to prevent recurrence. Another interesting variant. This is a granular cell tumor. So you can see it here. Okay. So this is again a reactive lesion which arises from the Schwann cells or their primitive mesenchymal precursors. They are very rare entity, and they're mostly found with female predilection, often occurring in the dorsal tongue. Okay, followed by buccal and labial mucosa. Other sites include palate, gingiva, and floor of mouth. So, in up to 15% of patients, synchronous lesions can be found elsewhere. So, that is something that should be borne in mind. They are firm, painless, relatively immobile, sessile or nodular appearing lesions with less than 1.5 centimeter in greatest dimension. So the interesting variant about this is that because it is arising from the Schwann cells, it has, like immunohistochemistry wise, it tests positive for all the neuroendocrine markers like, S100, Vimentin, CD68, Inhibin, P75, and PGP 9.5. I'm sorry, but we'll have to remember all of this at least from exam point of view. And management again is surgical excision and does not recur. The one thing we have to bear in mind in all of these, most of the lesions, is that conservative surgical excision itself will make sure that they don't recur. This is another interesting variant. This is also like a granular cell tumor. So but it is typically found in newborn, and it most commonly involves the maxillary ridge. Okay, maxillary alveolar ridge. Typically found in girls. So this is again an image of a congenital epilis in a newborn involving the maxillary gingiva. So it's a smooth surface sessile or pedunculated mass on the anterior maxillary alveolar ridge. They usually do not recur, and sometimes they regress without treatment as well. Okay. So vascular anomalies. So we can classify them into hemangiomas, AV malformation, and lymphatic malformations. So first we'll talk about hemangiomas. So hemangiomas are nothing but vascular tumors. They are true endothelial neoplasms. Okay, so they typically appear in childhood, a few weeks after birth, and they grow very rapidly. So because of that, intraorally they can cause mass effects, and we have to be very careful regarding that. In many patients, luckily, they involute over time with residual telangiectatic fatty or scar tissue. However, there's still a chance that they can involve multiple areas, especially in children with Sturge-Weber syndrome or Walnut-Landau syndrome. So mucosal hemangioma often presents as a soft, painless mass, which is red or blue in color. Like they usually have less than 2 centimeter in greatest dimension, and can extensively involve significant portion of the oral cavity or pharynx. So management, as I said, is surgical removal for lesions that do not involute or are aesthetically obstructive or they bleed easily. Okay, so these are the 3 things we should remember, which do not involute or which are obtrusive or which bleed easily. Okay, so capillary venous and arterial malformations, we can classify them according to the flow types or the vessel involved. So they can be high flow, which is arterial and arteriovenous, capillary or venous, which is low flow. So they are nothing but structural aberrations in component of vascular apparatus. Again, pardon me for the spelling mistake. They are slow growing, apparent at birth, and they never involute. So this is a very important differentiation between this and hemangiomas. Hemangiomas usually involute. These AV malformations and all do not never involute. So sometimes if they are like they are in childhood, but then like they are like they are found in adolescent age group, usually because of the hormonal changes such as puberty, they can increase in size, they can start causing symptoms. So about 0.2 to 0.5% is the prevalence. They may be firm, pulsatile, and warm. A very important like question is the diastrophy. So this is an image of a diastrophy where when we try to apply pressure on a suspected vascular lesion to visualize the evacuation of color, it differentiates smaller vascular lesion from other pigmented lesions. So when you can see here, so you put the pressure, you can see the difference. All right, and again, treatment is excision during biopsy because they can result in uncontrolled hemorrhage. So therefore, radiological imaging is a must to identify the vascularity of the lesion, and sometimes even embolization may be required. Okay, now going on to the lymphatic malformation. So these are nothing but macros. They can be classified into 3 different types. So they can be macrocystic, they can be microcystic, or they can be mixed cystic lymphatic malformations. So these images show a macrocystic, a microcystic, and a mixed cystic lymphatic malformation. So they can be localized or regional. They are nothing but abnormal proliferation of lymphatic tissue. So one of the most common congenital findings or malformation of lymphatic tissue that we see in that is the most favorite exam question is cystic hygroma. That's why I've given here. So the neck posterior triangle is the most common site. Second most common site is the tongue. So 80 to 90% of them are diagnosed within first 2 years of life. If it is in the tongue, it is one of the most common causes of congenital macroglossia could be this. Yeah. So they are slow growing, painless, soft tissue masses. Because they don't have a clear anatomic outline, dissecting tissue planes they can be very extensive than what we initially assess. So and they can also undergo a rapid increase in size secondary to inflammation, either from an infection or a hemorrhage. So larger hemangioma, as I mentioned before, can be life-threatening. Cystic hygroma is one common one. So the treatment is again dictated by the type, as I said. So they can be mixed cystic or micro or macrocystic, their anatomic site, the extent of infiltration. Sclerotherapy is, like most commonly, and we have to remember this, picabinil or OK432 injection locally can lead to a temporary involution, or sometimes bleomycin doxycycline can also be used, and usually this is preferred over the surgical excision because of their extensive involvement. And recurrence due to the lesion, recurrence can occur because the lesion being interwoven between muscle fibers, preventing complete removal. Just a note about other vascular growths. So like glomus tumor, and glomus tumor has been recorded, even though it's very rare in the oral cavity, there are case reports of it happening in the tongue. So again, most of it is, they can be secretory, non-secretory, often found around the carotid body and the vagus. Okay, now going on to neurogenic tumors, we have the traumatic neuroma. So we all know Valerian degeneration. We all know about the like the degrees of trauma to a nerve. So these are nothing but a reactive lesion, often due to an injury to a peripheral nerve. So what happens is, most commonly, it is seen in the mental foramen following a dental procedure where they give a local anesthesia into the mental foramen. So what happens is the sheath gets damaged, and the proximal end of the nerve alone proliferates into a mass of nerve. And they can be they're nothing but Schwann cells mixed with dense fibrous scar tissue. Most common site, as I said, is the mental foramen, lower lip, and tongue, where the areas of local anesthesia. Okay, so this is an example of a a traumatic fibroma involving the like neurogenic tumor involving the mental foramen. So patient will have reduced sensation and discomfort, pain and palpation on pressure from an overlying denture, and it can also cause constant pain. So surgical excision and recurrence is quite rare. Another entity is palisaded encapsulated neuroma. So again, this is also a reactive neoplasm seen in response to trauma. They're also solitary lesion, but they're usually found in the heart palate. So that can be one of the differentiating features. But histopathology is the most important thing. Okay, histologically they are well circumscribed, partially encapsulated nodule composed of spindle cells, exhibiting area of nuclear palisading, often admixed with axons. So again, EMA positive, S100 positive. Surgical excision is the treatment of choice. Okay, another entity, interesting entity is the oral mucosal neuroma. So this is how they typically look, and they are found in conjunction with MEN2B. So we all know multiple endocrine neoplasia. Amongst that, MEN2B, has mucosal neuromas are most commonly found with respect to MEN2B. So what are the components of MEN2B? We all know that, right? Like medullary carcinoma of thyroid, pheochromocytoma, marfanoid habitus, and mucosal neuroma. So they are found due to inherited mutations in red proto-oncogene, and more than the mucosal neuroma, it's the medullary carcinoma of thyroid that is very important, and prophylactic total thyroidectomy is indicated if the patient tests positive for proto-oncogene, then prophylactic total thyroidectomy before 1 year of age is suggested. And the most important thing that we have to remember is mucosal neuroma may precede other components. So that is what I wanted to stress upon today. Treatment again is going to be surgical, and neurofibroma and schwannoma. So this is the most common peripheral nerve neoplasm, and typically diagnosed in adults and adolescents, often involve the oral cavity and oropharynx. So they are again mixture of Schwann cells and peripheral neurofibroblasts. Multiple lesions, neurofibromatosis, that is von Recklinghausen disease. 70% of the von Recklinghausen disease, the neurofibromas involve the oral cavity. So tongue is the most common intraoral lesion. They are also seen in the buccal or the labial mucosa. So they present as soft, painless, slow-growing masses which are tender to pressure or palpation. Complete surgical excision is the treatment of choice. The important thing that we have to remember here is they rarely undergo malignant transformation into a sarcoma. However, if they are associated with NF2, then there is a good chance that 15% of them might undergo might develop into a malignancy. A brief word on ameloblastoma. I'm not talking about this in detail because it falls into the odontogenic tumors. So this is the most common neoplasm of odontogenic origin, and mainly develops from the primitive dental lamina related to the enamel origin in the alveolar bone. So commonly seen in third decade of life. In 85% of the cases, mandible is involved. That is the ramus and the molar area. So CT again shows a unilocular or a multilocular radiolucency with cortical bone expansion. Treatment is on block resection with 1 centimeter margin because they can recur. 22% recurrence rate is found, and half recurrences occurs within, lifelong follow-up is again recommended. Malignant transformation can occur. It can develop into an osteosarcoma. So histologically, they are nothing but solid infiltrating tumors with a follicular or plexiform pattern that exhibit an element of cystic change. Okay. So we're coming into the fag end of the presentation. So another common entity that we come across is the pleomorphic adenoma. So pleomorphic adenoma, we all know, typically arises from the parotid gland. In the oral cavity, they are usually found in the minor salivary gland. Okay, so the minor salivary gland being unencapsulated serum mucinous gland. So often underneath is a submucosal mass that is seen through in the oral cavity and oropharynx. So we have to remember that 40% of them are benign, and amongst which pleomorphic adenoma is the most common one. We should also remember that minor salivary gland tumors, most of the tumors are malignant. So that is something that I also want to reiterate. So in the oral cavity, a pleomorphic adenoma is most commonly found in the hard palate. Other sites include the lip, buccal mucosa, alveolar ridge, floor of mouth, and tongue. They are often smooth and slow growing, but they're usually identified very early. So this is a buccal this is a picture of a pleomorphic adenoma involving the ramus near the retomolar trigone area. So treatment is again complete surgical excision. The one big advantage with that is that usually they don't achieve a very big size, so they're typically identified early, and therefore we can remove them completely. All right. So CO2 laser is often recommended mainly because of for the purpose of hemostasis. Another common entity that we see in the oral cavity that all of us tend to miss is, misdiagnosis a lipoma. So lipoma, as we know, is a benign mesenchymal tumor of mature adipocytes. They're very rare and often seen above 40 years of age. So they occur in the buccal mucosa and the tongue. So they appear as an yellow or an orange mass with a thin epithelial surface. Okay, so they can be classified into multiple types. So they can be a fibrolipoma, there can be a spindle cell lipoma, there can be angiolipoma, there can be mixed lipoma or intramuscular lipoma. I'm not going into the details of it because it's a histological classification, and I think the name itself says what is what. Most of the time, we can just let them be. Nothing is, it's not going to harm the patient. However, in many patients, conservative surgical excision is required. So the biggest advantage of in an oral cavity lipoma is that when compared to an intramuscular lipoma, the recurrence rate is very less because it's easier to identify the plane and ensure complete excision. Just a last word. So tumors of muscle. So these are also seen in the oral cavity. I just want to tell that. So they can be either a striated rhabdomyoma or it could be from the smooth muscle, which could be a leiomyoma. So they're exceedingly rare. Okay, oral rhabdomyomas typically occur in the tongue, and vascular leiomyomas are usually solitary lesions involving multiple oral sites, typically the tongue, the buccal mucosa. So local surgical excision is the treatment of choice. Thank you. Hello?
Yeah, ma'am, you're audible.
Yeah.
Excellent. Good evening, Dr. Krishna. This is Dr. Nilima this side.
Hello, ma'am. Good evening.
Hello. So that was an excellent talk and very nice self-descriptive pictures you used because oral cavity lesions, many of them look alike. So that was very nice. Thank you so much.
Thank you, ma'am. Thank you.
Maybe there will be some questions. Let's see in the chat box if there are any.
Sure. I'm not sure there are much of questions. Yeah. There aren't any questions as of now. I can't see.
Most of them are asking for the presentation.
Yeah, I think I
think your presentation must have been recorded, I believe, and if it has been recorded, then NBE will post it on their website. So interested participants can just go through the presentation over there.
Sure, I think Right. I think people are just asking for the presentations also. I think they have recorded it. Yeah.
Because oral cavity lesions, there are a huge number of these, and most of them, as you said, that we should wait for about 2 weeks. Some of them are self-healing, and but after that we need to prove the diagnosis using the histopathology examination. So that is that. And also you highlighted the management of hemangiomas, AV malformations. They are mostly difficult to treat, and since they are extensive, so use of sclerotherapy and sclerotherapeutic agents is important.
Yes, ma'am. Yeah. So
Yeah.
that's something we see in day-to-day practice. So I think, yeah. So I wanted to stress upon that. So
Yeah.
I hope they have learned. I mean, I hope I was able to at least clear up some of the doubts.
Yeah. Because now the malignant part is a different part in itself, because then the management of malignant oral cavity and oropharyngeal tumors, that's a big topic in itself. So you have very nicely covered the benign lesions. So,
Thank you.
so I don't think there are.
Any questions?
Thank you, Dr. Nilma. Thank you, Dr. Krishna, and all attendees.
Thank you.
Yeah, so I think we can conclude the session, Dr. Krishna. Thank you so much.
Yes, ma'am. Sure. Thank you.
And as for the PPT, I think it would be available on the NBE website. If not, then maybe
I can send
yeah,
share it
people
with
can
you.
contact you directly and
Yeah.
get the PPT.
Yeah. I will do that. Yeah, sure. Okay. Thank you, ma'am.
Thank you. Thank you so much.
Thank you.
Have a nice day, and every
You too. Happy New Year.
participant, I wish you Happy New Year to all the participants. Dr. Krishna,
Yeah.
Happy New Year to you too as well.
Thank you.
The
Thank you,
next
ma'am. Thank
webinar we will have in the new year 2024.
24. Yes.
Yeah.
Yeah.
Yeah.